One of our patients, he is a plastic surgeon.
Hello.
And we have done a Bankart repair for him. So he is able to do handstands after the arthroscopic procedure. So the shoulder becomes unstable. He had a problem with shoulder dislocation. And we did a arthroscopic Bankart, and now he is able to do handstand after the procedure. So this kind of results we can achieve with arthroscopic procedures. Unfortunately, open surgeries, if you do this kind of procedure, this kind of results you will not be able to achieve. So that is what I am trying to emphasize. Is it is not about treating; it's about giving functionality. So that is important. So we have discussed this. Now this is another new thing that we do. So you must have heard about carpal tunnel problem. So carpal tunnel traditionally open surgery used to be done. So now we are doing an arthroscopic surgery. So this is the endoscopic procedure. We do it with a keyhole and we remove it. So this is a bed and we release it up with the. So it is a small incision of about a centimeter, and we can release the carpal tunnel with an endoscope. So that is a very new technique that we are doing. So no need of an open surgery for carpal tunnel syndrome. What is the carpal tunnel syndrome? Okay. So now again, you may have heard much about tendo Achilles repair. So you must have heard about tendo Achilles repair. So previously an open straight long incision was given, and then wound healing problems were there. So now we are doing a procedure which is called as a percutaneous tendo Achilles repair. In this we pass small needles like this. So we avoid making small big incisions, and this is very good for patients who have problems of wound healing like diabetic patients, those in which there is a risk of wound infection. So this is good because you can do a sort of a very small incision, and you can pass these wires, and then in the end you repair it like a percutaneous. So you don't have to open that thing. You can do everything with a percutaneous approach, everything like an endoscopic. So no big incisions, very less chances of wound opening or wound pixels. Okay, so this is how you close it up, and this is a small incision of about a centimeter. Now ACL surgery is one of our most common surgeries.
7 mm offset. Here I am using a 7 mm offset.
So you can see that this is our base surgery.
And then ask the assistant to drill into the adjustable loop you can do that. So now our graph is prepared. So here you can see the bigger lever first. So the 8 lever can be used to drill the first partial base.
So basically what happens in ACL, we make a graph and we put it. So this is the most common surgery at our center. So you can take it out, and this is the special button that we have done. This is called the E2 button flex.
Very good. Very good.
So this is the final. This shiny structure is the ACL ligament that is inserted. Okay.
My second wire to this.
Okay. So this is the ACL surgery that we do. This is the most common surgery that we perform. Now there is a root there. What is root? Anybody know what is root? Meniscus root. Now this is a very important concept. Root is jad. पेड़ का जड़ is root. So meniscus is attached to the tibia with the attachment that is called as a root. And if this root is torn, जैसे पेड़ की जड़ उखड़ जाती है, तो meniscus उखड़ जाता है, and that leads to a very rapid progression of osteoarthritis. That Dr. Himanshu sir mentioned that then it starts going into varus. So now important thing is we should attach the meniscus to the root. If we are able to do that, we can prevent osteoarthritis, we can prevent knee replacement. Okay? So this is important. So what we do is we do a technology which is called as a root fix technology. With root fix, we attach the meniscus root onto the bone. Okay, so this is called as a root fix technology. This is our patented technology, and this surgery can actually reverse the osteoarthritis. This can prevent the knee replacement procedure. So you can see that we are doing, this is an animated version and this is the actual surgery being performed. What we need to do is we need to pass this jig and we pass the anchor onto the tibia. The place from which the meniscus is torn, we attach it right there. So this is a drill. Then we pass a sleeve, and over that we put an anchor, and with that anchor we repair it. So this is the actual video of the anchor being deployed, and this is the animated version. This is the anchor you can see over there, and then we pass sutures onto the meniscus and repair it on its place. So this is how we repair the meniscus onto its place. So if you repair the meniscus, so meniscus is the shock absorber. If you repair the meniscus will take the load and it will not cause osteoarthritis to progress. So that is how we prevent or we avoid the knee replacement. So this is a very unique technology that we do, and along with that we occasionally add ITP orthotomy, as Dr. Himanshu said in some cases. And this technology is actually a breakthrough technology of regaining the longevity of the knee. You can live 10 years, 15 years more longer with your natural knee. So similar, so these kind of complex tears. So again, these are complex tears. Previously, surgeons used to do meniscus removal surgery. So that is called as a meniscectomy. This is a very bad surgery because when you do meniscectomy, the patient's knee will develop osteoarthritis very fast because the cushion on the shock absorber is lost. So with these sort of surgeries, we put new and new devices, we put sutures and we repair the meniscus into its place, thereby preventing the shock absorbing capacity and leading to a longer life of the knee. So these are the unique techniques that we do. We pass sutures, we repair the meniscus in different fashions. So this is a very bad meniscus. Conventionally, it is the standard treatment is to do a meniscectomy. So you may have heard of arthroscopy done at many places, but most of the places they will remove the meniscus. They will not focus on repairing it. Unless you repair it, you will not get a good result. And what is important in long run is a good result in the long term. The knee should not develop osteoarthritis. Knee should be stable and it should last long. That is the purpose of doing our procedure. Okay? So repairing the meniscus is the key. So always insist your patient should do meniscus repairs as compared to resection. Now again, this is a meniscus realignment surgery. So for early arthritis, this is a starting phase of arthritis. We can place many anchors into the meniscus. So here we are starting to place anchors. Okay? So here we start putting anchors at multiple places. So what we want is the meniscus is extruded. That is why there is arthritis. So we try to bring meniscus in. So normally, starting of osteoarthritis, what happens? The meniscus is intact, but it becomes non-functional. So we make them functional by this realignment, meniscus realignment surgery. We put multiple sutures into the meniscus and try to bring the meniscus in. So if the meniscus is intact and functional, osteoarthritis will not progress. So we try to bring the meniscus in, repair it circumferentially, and to make it functional so that the arthritis does not progress further. So these multiple suture anchors are placed, and then there are special devices with which we are repairing the meniscus onto its place. Okay. So this is the anterior suture, and after that we pass the posterior suture, that is the root fixed technology I talked about earlier. So this is the repair that we do. So the meniscus is into its place anteriorly. After that we go on the posterior aspect, and there we implant the root fixed anchor at its place. So that will lead to a better reduction of the meniscus on the back. So everything of the meniscus comes into the joint, and it will serve as a load bearing structure. So the purpose of the meniscus is to bear the load, and it is a very important structure for longevity of the knee joint per se. So this is the root fixed anchor. This is the unique anchor that we have developed, and it deploys into the root, and from there we repair it nicely, and then you can see that this is passing. This is almost the same video that we saw earlier. Dr. Himanshu discussed about. Then there is a unicondylar replacement. So we don't have to replace the whole joint, we just replace half of the joint. And with this also the patient will have much better functionality as compared to a total knee replacement. Again, we can do a lot of advanced meniscus repairs. Then there is a hip repair. So we can do hip arthroscopy and lateral repair. So for hip also, if the patient is coming to us at the right place, right time, we can do arthroscopy in the hip joint also before the hip replacement. So if it is a stage 2-3 AVN, we have to do a hip replacement. But before that, we can do hip arthroscopy to prevent the knee replacement or hip replacement or delay the hip replacement surgery. So this is the video of the hip labral repair. So this is the hip joint. This is the hip, and the upper part is the acetabulum, and we repair the labrum with the arthroscopic techniques. With this thing. Okay. So this is another video of hip arthroscopy. This is actually a PVNS problem, and we remove the PVNS and remove all the synovium. So this is a small loose bodies into the hip joint, and we can remove it from the hip joint also.